Hi everyone, my name is Danya Arif and I'm the Assistant Director for the Maternal and Child Health Program at IRD Global. And today I will be discussing our work on integrating humanities in healthcare. So that's a mixed method study for development and testing of a humanities curriculum for lady health workers in Karachi, Pakistan. So before I go into the detail of the study itself, a little bit of background about our study setting. So Pakistan is among one of the countries with the worst maternal and child mortality ratio. So just to give an idea, the Pakistan's under 5 mortality rate is about 62 per 1,000 live births and 186 per 100,000 live births for the maternal mortality ratio. And against this backdrop, lady health workers are a specific cadre of health workers that play an integral role in catering to more than 60% of Pakistan's population, particularly in providing preventive and curative maternal and child health services. But despite the integral role that they play, there is a challenge that these lady health workers are inadequately trained and they're not provided enough support. They also face occupational stress challenges, particularly because they're overburdened. They have low financial compensation. They face security concerns. And as a result of all of these factors, they are faced with a lot of external stressors, which lowers their well-being and limits their ability to provide humanistic care to diverse communities that they serve. So against this backdrop, our intervention was centered around developing a humanities-based curriculum for these lady health workers, particularly to hone some of these character skills in the lady health workers. We developed this humanities-based curriculum that was then delivered in a local language through interactive sessions. And some of the key outcomes that we were looking to improve through the intervention are listed below. So they were a higher sense of purpose, empathy, and connection with the communities that the lady health workers served, increased compassion within the lady health workers, improved communication, increased joy, and an enhanced sense of self-worth. So just to summarize, the key objectives of our study were therefore to develop and refine a humanities curriculum that consisted primarily of local art and literature. We also developed and validated a contextually appropriate quantitative survey tool to measure the key character strength outcomes that were listed on the previous slide. And then we also deployed the curriculum on a limited scale and measured its impact on participating LHWs sense of purpose, compassion, connection to the community, and their interpersonal communication skills. So briefly mentioning the methodology of our study. So we followed a 4-step approach. So in the first step, like I mentioned, we developed the humanities-based curriculum, which was tailored to the requirements of the lady health workers. So it went through an iterative process where we held focus group discussions with the lady health workers. We pre-tested the curriculum with them. And the final curriculum was heavily grounded in the local context. So it had local literary texts, prose, poetry, as well as interactive activities that were delivered to the lady health workers. And then in addition to the curriculum, we also developed a character strength instrument that I'm going to discuss in a little bit more detail in the upcoming slide. In the next step, which was our key intervention delivery, where we delivered the curriculum to 48 participating lady health workers in 2 towns of the city of Karachi between June and September 2021. And the curriculum was delivered through a facilitator. The lady health workers were divided into 3 groups. So they had the curriculum had 12 modules that were delivered over a 12-week span. Then in the third step, we evaluated the intervention and we followed a life cycle approach, which was then combined with the mixed methods data collection, whereby our quantitative evaluation was done by the character strength instrument. So we did it pre-post at the baseline end line, and then we also did a 4-month follow-up after the intervention had ended. And then our qualitative analysis was done through in-depth interviews that were conducted with a random sample of 12 participating lady health workers and then 10 lady health supervisors who directly supervise these lady health workers during their day-to-day activities. And then as a last step was dissemination of our study results to both the stakeholders and government as well as through to the academia. So like I mentioned, this slide outlines a little more detail of the instrument development process. So again, in the first step, when we were developing our character strength instrument to gauge the impact of our character strength outcomes, in the first step, we reviewed existing literature to identify the potential scales. Then in the second step, we evaluated and shortlisted the scales through expert consultation. In the third step, we adapted and translated the shortlisted scales. So they were essentially adapted to the local context and then translated into the local language. And then again, the development of the scale was also an iterative process whereby we also did then cognitive interviews with the community health workers using the full instrument. So we knew it fit in with the local context. And then as a last step, we also pre-tested the full instrument with community and facility health workers to make sure that it was reliable and valid before we implemented it at the before and after our study. Then I'm going to now move on to the key results that we saw as a result of delivering the intervention. So my first slide is on the key results from the process evaluation that we conducted. So overall, and just to give a little bit of background, because such an intervention was being conducted for the first time, we did have a key process evaluation component that we had incorporated within the intervention just to see that it was being implemented as intended. So we looked at these 4 key measures. So we looked at the participant attendance, and we saw that on average, more than 90% attendance was maintained throughout the sessions. And 71% of the LHWs, they maintained 100% attendance across all sessions. Then we also monitored the engagement levels of the LHWs during the sessions. And on average, we saw that one participant spoke about 13 times during each session. And then as far as the participant feedback is concerned, we asked the participants to rate each session after it had completed through a short survey. So the average rating that the participants gave regarding the usefulness of the curriculum was 9.7 out of 10. And then the average score that they gave to the success of the sessions was also 9.7 out of 10. And in addition to the participant feedback, we also requested the facilitator to share their feedback at the end of each session. And so based on what the facilitator provided us, the average rating that the facilitator gave to the participant responsiveness was about 9.4 out of 10. Then moving on to the key results from the quantitative component of our evaluation, which was the character strength survey. So this slide basically shows the pre-post scores, so the baseline versus the endline scores, and my next slide would then track the scores from the baseline to the follow-up, the 4-month follow-up period. So here, just to provide a little bit of an orientation, and the first column, we have listed down the 5 key scales that we had adapted and developed our key character strength instrument from. And then we have also, so the highlighted sections are the key 5 scales, and then we've also listed their subscales. In the brackets, you can see the scores for each scale, as well as the number of participants that actually were surveyed on these scales. So the next column shows the baseline scores, and then the means of the baseline scores with the standard deviations, and then the endline scores with the standard deviations. And without going into too much detail, I think what is relevant is to look at the column of differences between the baseline and the endline scores. And we do see positive differences across all the scales, which essentially means that our key character strength outcomes that were being measured through these scales, we saw an increase in all of those 5 character strength outcomes. And then the last column shows the p-values. So we see that the scores for the scale of socio-cultural empathy, as well as the scale of the socio-cultural empathy, the religious perspective, and the Jefferson scale of empathy, they showed statistically significant increases at the end line. So again, this basically shows that the curriculum, it helped increase empathy, as well as interpersonal communication skills among the participating lady health workers. And then this slide basically compares the baseline with the follow-up the follow-up scores of the scale that we conducted 4 months after the intervention had ended. So again, the first column shows here the baseline scores, and then we have the follow-up scores at the 4-month mark. And once again, the differences column here, they show positive scores for all of the scales, which means that the impact was sustained even at the end of the 4 months post intervention. And again, we do see that in particular, the outcome of empathy, so the scale of sociocultural empathy, both the original scale as well as the religious subcomponent that we had developed, as well as the Jefferson scale of empathy, they all showed statistically significant increases in the follow-up scores relative to the baseline. And just one point, for the scores where we do not see a statistically significant increase, partly that is because the scores at the outset, at the baseline, were very high to begin with. And then now I move on to the qualitative component of the evaluation, which is the findings from the in-depth interviews that we conducted with the lady health workers and the lady health supervisors. So just to summarize the key themes that we that we saw post our in-depth interviews with the 12 randomly selected lady health workers. So all of them, they found the curriculum and the training that we had imparted as relevant to their role as frontline health workers. They were able to apply those learnings in their practical life when they interacted with the communities. They were also able to practice better self-care and advocacy for themselves, and understand and better connect with the communities that they serve. So these are the sort of key themes that we saw from the results of the in-depth interviews. And then I think it was pertinent to also share some of the quotes that we saw. The lady health workers, they provided an insight into the impact of the training. So one of them said that the training has given us the strength to move forward, to think about ourselves, to take out time for ourselves. And then another one mentioned that I utilized the benefits of our training in my community. I started using easier language. If I am able to understand them, then they should also be able to understand what I am saying. So they just sort of underscore that even just the immediate impact of the training in terms of how the lady health workers perceived themselves, and then how they were able to better provide care to the communities that they served. And then in addition to the participating lady health workers, we also interviewed 10 lady health supervisors who are responsible for directly supervising the lady health workers in their day-to-day work. And so the lady health workers, basically, the lady health supervisors, they mentioned that the workers were able to share their training stories and experiences with their other fellow participants who were not able to attend the training. The training was also, they found that the training was relevant to the lady health workers' work, and then similar trainings, they actually requested the study team to have similar trainings for other lady health workers and lady health supervisors as well. And then lastly, they also mentioned the positive impact that they saw in the lady health workers in terms of how they had improved their communication skills and how they showed more confidence and self-worth while interacting with both their peers as well as with the communities that they serve. And then one powerful quote that we saw was one of the lady health supervisors mentioned that I went with them, which means the lady health workers, for the measles campaign, and saw how they were able to convince those people who were refusing the vaccine administration. And so again, a few more quotes, just because what we did find at the end was that in addition to the quantitative improvement that we saw in the character strength outcomes, what was more powerful was the kind of stories that that the lady health workers themselves told us and used to share their perspectives on the curriculum, on the training. So one of them mentioned that I loved discussing the things about my past and my own life. Before this, I had never thought about my own life. But after this training, I've learned to think and have realized how much I have done. And another lady health worker mentioned, I had lost everything. I had lost myself. I was broken. And after this training, I have felt alive again. I realized that I too am a human who needs to be taken care of. And my family and siblings have also realized this positive change in me. So these are, again, just a few very powerful stories that the lady health workers shared with us. And this, again, it sort of really added color to the quantitative results that we were seeing as a result of the intervention. And then I believe this is, again, my last slide, which summarizes some of the key takeaways and the way forward. So we basically, as a result of this pilot study, we saw that a humanities-based training that leverages local arts and literature is a feasible intervention that can effectively nurture the key character strength outcomes among the lady health workers. And most notably, we saw that the training resulted in a significant 10-point increase in the pre-post scores for empathy and interpersonal communication and connection among the lady health workers. From the lady health workers' perspective themselves, they found that this training was useful for their professional and personal lives, and they enjoyed the innovative and novel content that was provided through the trainings. And then in particular here, like I mentioned at the start, that lady health workers, despite the centrality of their role within the maternal and child health, care within the country, they do face a lot of challenges. They play a very integral role in polio eradication within Pakistan, and then more recently in the COVID-19 pandemic. And so, in addition to the theoretical training that they're provided as part of joining their work, a humanities-based training is therefore essential to not only improve their own well-being, but then there's literature out there to support that improved well-being of the lady health workers will eventually translate into improved health outcomes of the people that they serve as well. And then as a way forward, our next step is now to take this work a little bit forward and investigate the impact of similar trainings among other cadres of frontline health workers, notably the vaccinators that are responsible for vaccinating and providing childhood immunization to children in Pakistan. And then also evaluating the impact on the long-term health outcomes of the populations that are served by these frontline health workers. So that's something that our team is now currently working on to take our work one step further. And I believe I'm going to stop there, and I'll be happy to take any questions. Thank you.